Hi, it's Dr. Centeno. Getting started just a few minutes late today. Thank you for joining us. You've got the power. So today we've got an interesting topic, and it's going to be a little bit intense because I'm going to be talking about infectious or environmental causes of CCI or ligament damage. And what's interesting about this topic is I have a good number of patients that I've talked to through the years that are convinced that things like mold exposure or chronic Lyme disease or environmental triggers, MCAS, mast cell disorders, etc., might be the cause of their CCI or ligament damage. So I'd like to review what we know about this today, what we don't know about this. Are these connections scientifically credible? Do they just exist in the cordoned off world of functional medicine and not at all in the traditional medical research? What does all that look like? So that's what we're going to talk about today. Now, I have to warn you, usually I only do about a 5-minute presentation, but this topic is so deep and wide that I may take more like 15 minutes or more to get through the original or initial presentation to get to questions. But as usual, you can ask any question you want, whether it's this topic or something else. But we're going to go into this topic of infectious or environmental causes of CCI. We'll get into autoimmunity and autoimmune causes like MCAS, etc. So let's dive into this now. And I'm sure more people will join as we go. I'm going to share my screen here. Okay, so let's start out with a presentation. And sorry about that. Just got a phone call I had to get rid of. Let's see here. So, lost my train of thought there. Okay. So, infectious or environmental causes of CCI, a review of what we know. So again, we're going to be talking today about infectious causes like Lyme disease and whether or not we know Lyme disease can cause CCI. Other causes like mold, CIRS, MCAS, gluten intolerance, lots of different things. So the scientific mantra, I love these three phrases. What do we think? What do we know? What can we prove? So what do we think is a lot of what I see out there in the functional medicine community when we're trying to link, let's say, a mold exposure to CCI, meaning we can use the research and we can say this might go to this, which might go to that, which might go to something else, which then links it to CCI. So that's in the lowest level of evidence, the what do we think category. Now you can make what do we think discussions look really, really scientific by throwing lots of big words in there, but they're still at the what do we think level. Then we get into the next level, and that is what do we know? And what that means is that we have some experimental evidence, let's say from case series or from case reports in real patients, and it's higher level information than just looking at the basic science of what do we think, but it's not yet at that highest level of what can we prove. And in medicine, regardless of what it is you do, that requires a randomized controlled trial, and that would be the highest level of what it is we're talking about. So that would be a randomized controlled trial that connects in things like mold exposure to craniocervical instability. So we define what craniocervical instability is. Some people get exposed to mold, some people don't, and we see who ends up getting craniocervical instability. So if you read my blogs, I'm clearly not a traditional medicine fanboy. In fact, I'm pretty critical of my own profession quite a bit. And I really use this type of thing to make sure that what we're talking about is scientifically supported, whether or not it supports traditional medicine or not. So I'm not a fanboy of traditional medicine, and I don't believe that everything needs a randomized controlled trial to be accurate. But it does have to have some scientific validity if we're talking to patients about it. And in fact, a little fun fact or not so fun fact about me that you may not know, my wife has a form of mast cell sensitization, likely caused by eating a fish that had this particular Chicotera toxin in Florida. I think it was early last year, somewhere around there. So I've experienced this stuff firsthand in my own life. So there's two different ways that we can make diagnoses in medicine. You've got a biomechanical diagnosis and a systemic. Now, the nice thing about biomechanical diagnoses, and the reason why I like them, is you can touch and feel them, right? You can do a physical exam. You can confirm or deny findings that fit with the diagnosis based on imaging. Whereas systemic, you got a little bit of a problem. You're now reliant largely on diagnostic tests. So biomechanical diagnoses are physical exam, tenderness, range of motion, instability, swelling, spasm, sensation, reflexes, lots of information you can put towards confirming or denying a diagnosis. And then you can do the same thing with imaging. So that's really nice because you can take some test out here and see whether or not it really fits with, for instance, your physical exam, or whether or not the complaints match the physical exam. But when we get into these systemic diagnoses, like we're going to be talking today, they're largely reliant on a diagnostic test result. And the problem with that is that the validity of each test needs to be established. And that's not so easy in this world of functional medicine, because those are not FDA approved tests. So if you get a chronic Lyme disease test, that's not an FDA approved test. That's a laboratory determined test that doesn't go through any FDA approval process at all. And so you'll get wildly different values from different labs, and certain labs are going to produce more false positives. And again, there's no oversight from the FDA on these tests. So the doctor is kind of at the mercy, as is the patient, of the accuracy of that test. And please don't assume that all these tests that you're seeing and you're getting have that accuracy linked back to a diagnosis. They really don't, and no one really knows in many instances. So again, today everything we'll be discussing is in this systemic category, where making a diagnosis is again reliant on a test result, and hence the accuracy of that test result is paramount. And oftentimes, we're not talking about FDA approved and monitored tests to make sure that they're accurate. So that's one of the problems with this entire category. So this is the theory for an infectious cause of craniocervical instability. You've got some infection like Borrelia that is destroying parts of the matrix that make up a ligament, and hence you end up at the end of all that with ligament damage. And the theory for systemic inflammatory cause for CCI is you have some sort of toxin or trigger, and then there's some sort of abnormal systemic reaction, meaning that most people with that toxin and trigger aren't going to get any type of systemic immune reaction. But some people will, whether that's genetic factors, whether that's just the way their immune system's set up. And that's where we see things like MCAS and autoimmunity. And then that leads to chronic inflammation, which then leads to ligament damage. So this is what I hear patients discussing as reasons for their CCI that doesn't involve the two biggies that we see: some sort of trauma that's capable of causing CCI, or hypermobile EDS. And so we see patients or I've seen patients over the last number of years talking about their Lyme disease causing this, a mold exposure causing this, COVID-19 causing this, their MCAS being a cause, dietary issues, or just chronic systemic inflammation. Now, some of these are things I hear. These are the big three that I hear. A lot of times we'll talk about MCAS as more of a side bystander, although there are people in the functional medicine community that clearly believe that MCAS can cause by itself ligament damage. And then, we'll see less talk of things like gluten intolerance causing this sort of issue, or things like oxalates replacing sulfur, but I have heard that discussed in some of the patients I talk about. And then we'll talk about chronic systemic inflammation, because that's one that could have a role in all this. And so we'll see what kind of research lives there. So chronic Lyme disease, this is probably the single biggest thing I hear from patients as a rationale for why they have CCI or other ligament damage being caused by something that's not trauma or HEDS. So what do we know? Well, I took a lot of time with this one. And in fact, I went deeper than just a National Library of Medicine search. For instance, I found one interestingly referenced review paper. Then I went back and looked at those original citations to see if I could pull out something that could credibly link Lyme disease and craniocervical instability. So we have two European dog studies that one goes the direction of saying there is no relationship between Borrelia and a ligament rupture. The other one saying there could be a connection. The one that says there isn't a connection is higher level than the one that says there is a connection. So right now I would say that that's a no on the dog research. We have a single case study, which doesn't mean a lot, where they were able to culture some Lyme spirochetes from the ligament samples they took during a trigger finger release surgery, but that's just a single patient. And then this is an interesting one because we have a case series of about 60 patients where they looked at IgG antibodies or chronic antibodies. They looked at this other test, which was a lymphocyte test. And they tried to link these test results showing that the patient had a Lyme exposure to functional MRI results showing craniocervical instability. Now, the problem is they didn't really define what was CCI and what wasn't. And another problem is the paper is in German. So if there's any native German speakers out there, I'm happy to send them this paper and maybe they can dig in deeper than I was able to get. And the biggest problem with this study was there was no control group at all. So we don't know the number of people walking around out of the normal population without this issue that would have these tests positive. But this study did establish a connection between the two, but it's one study, 60 patients, there's no control group. So not high-level evidence of a connection, but certainly suggestive and worth further exploration. Now, regrettably, that's the height of all of this. The research quality now goes down from here. So the next one was looking at mold and CIRS to see if there's a connection between that and ligament damage. So does the data support that mold toxins can destroy the upper cervical or any ligaments to the degree of causing severe disabling CCI? And regrettably, there's just nothing in the U.S. National Library of Medicine that connects these two. And you might say, well, that's all traditional medicine stuff. Not necessarily. National Library of Medicine contains lots and lots of basic science research that is not even medical. And there's nothing in here, despite multiple different searches under mold exposure, mold, specific mold types, ligament. I couldn't find any research published on this one. Now, I have seen this circuitous argument, and these are the two references down here of where I saw this circuitous argument on these two functional medicine websites, that there's some causal connection between mold exposure and problems with TGF-beta family signaling. And in particular, they were talking about TGF-beta 1, which has to do with remodeling of tissue. And in particular, they mentioned this 11.352b haplotype, which is just basically a type of genetic makeup. And that in turn caused connective tissue disruption in the spine. At least that was the theory. But in trying to research this on the National Library of Medicine, as you can see, this haplotype doesn't even get a single result back. So hard to do any research on this connection. Now, this all sounded very scientific. There was lots of different studies mentioned here, but they were all that what do we think category, not the what do we know category, meaning I think that this is connected to that, which is connected to this, which is connected to that. And at the end of the day, it's still a tenuous theory, regardless of how much scientific speak you throw in there. I've also seen this paper cited on websites that talks about TGF-beta 1 being a problem for CCI patients. This is a rat study. It actually talks more about mast cells releasing TGF-beta 1 than anything else, and it has nothing to do with craniocervical instability. And I've seen this paper again cited to connect these dots regarding TGF-beta superfamily signaling problems and CCI, but this is actually vascular EDS. Just so that you fully understand, vascular EDS is an extremely rare problem. And so for hypermobile EDS, that's about 1 in 5,000. For vascular EDS, that's about 1 in 90,000. So you can see it's many, many times more rare than hypermobile EDS. And by age 40, 80% of people with vascular EDS have had some bad thing to take them to the hospital. So if you're 40 or older and never been to the hospital for vascular problems related to EDS, you probably don't have vascular EDS. And none of this has anything to do with CCI patients that we see. So I'm not quite sure why this was used. So COVID-19, this is another really big one that I see. I see people online telling me that they believe that their CCI was caused by COVID. So let's look at that research. Is there anything out there? Now, with regard to ligaments or any musculoskeletal problem, it's believed that in the small subset of patients that get infected with COVID-19 that have more severe COVID, that inflammatory response can make old problems hurt. And I've experienced that myself. After the second vaccine, which I had a Moderna vaccine, I got a whole body inflammatory response. Every single problem I ever had, whether it had been talking to me that last year or not, talked to me that night. So I have experienced that one personally. And we know that musculoskeletal problems, or at least complaints, are pretty common in long COVID, but no one really knows what this is caused by. Is it caused by long COVID? Is it caused by inactivity? So this is kind of poorly understood at this point. So bottom line is, with COVID and all musculoskeletal complaints, our knowledge is pretty rudimentary right now. And I couldn't find any connection in the literature between ligament damage and long COVID or COVID-19 exposure, and certainly nothing with regard to CCI. Then we've got MCAS and or types of autoimmunity. So again, let's go back to that same thing we talked about. Normally here, there's some toxin or trigger, and then we get an abnormal immune response that most people don't have. That causes chronic inflammation, and that causes ligament damage. Now, the theory is that since diseases like rheumatoid arthritis can damage ligaments, lupus, then other causes of autoimmunity must do this as well. And so we do know that these autoimmune diseases, rheumatoid arthritis, scleroderma, and many others, including lupus, Marfan syndrome, can have a ligament component. The problem is that without direct published evidence, it's a stretch to go from those diseases into these more functional medicine diagnoses. So, for example, this is what happens in a rheumatoid arthritis patient, where the dens gets completely eaten away. And I haven't seen any chronic CCI patient, other than maybe one who probably had rheumatoid arthritis, that with MRIs looking at anything like this. So MCAS causes ligament damage. So this is another one. Normally I hear, like I said, MCAS being a bystander, but I have seen some functional medicine people talk about MCAS causing ligament damage or being heavily involved in all of that. And the concept there is this sort of chronic inflammation, and we'll go over that in just a second. But this is an interesting paper I found. Do mast cells have a role in tendon healing and inflammation? And this is a problem that we see a lot in the literature, where the focus is on tendons and not at all on ligaments. So the answer is there could be some relationship between tendinopathies, perhaps, and mast cell. But again, this is still pretty low-level evidence. But we generally see in the literature that ligaments are not mentioned at all. Diet. So gluten intolerance. So you all know celiac disease is pretty severe, and that includes wasting, etc. Here we're just talking about sensitivity and tolerance. The concept here is that this causes chronic inflammation. That chronic inflammation then leads to problems. Another one I've seen is oxalates displacing sulfur. And this is the link I sourced that from, that concept, and not much research. I couldn't find anything in the National Library of Medicine, even on the basic science or animal research side, talking about oxalates displacing sulfur and collagen and that causing weakening of ligaments. You need to realize that, again, this is one of those things where you can use a lot of fancy verbiage here, but you're still got a pretty tenuous theory where you're saying because oxalates can replace sulfur in collagen molecules, that may weaken the collagen, and hence that's leading to ligament problems, and hence that's leading to CCI. All of these things have been reported to, the oxalates being caused by yeast fungal overgrowths or gut dysbiosis. So those problems apparently cause the oxalates, which then replace the sulfur. So these problems create oxalates, apparently is the concept. The sulfur then gets displaced out of the collagen molecules, and then the collagen weakens. But again, even at the basic science level, there's really no research on this at all. How about an abnormal gut microbiome causing CCI? Now, this is an interesting one, and certainly one that we'll learn more about here over the next decade. But we do know that there could be a link between osteoarthritis, not CCI, and what's in your gut as far as your microbiome. And we know that from interesting animal studies that you can feed mice a high-fat diet and get them big and fat and cause a metabolic syndrome. And then those mice can develop knee arthritis, and then you can fix their gut and the arthritis gets better. So that's promising, but again, it's not a human study. So does that work in humans? Who knows? I don't think we know the answer to that at this point. And this is an interesting one talking about patients with back pain having an abnormal gut microbiome. Is that medication related? Is it caused by something else? Who knows? But again, nothing that I found on spinal ligament damage being caused by problems in the gut with regard to the gut microbiome. And then finally, chronic inflammation. Listen, single biggest cause of chronic inflammation out there is metabolic syndrome. So I'm not sure why we're looking for zebras when we have lots of horses out there. What I mean by that is that metabolic syndrome probably impacts a third of all U.S. adults. where you've got, the patient is overweight, they've got some elevated blood pressure, high triglycerides, they're starting to get insulin resistance, which is prediabetes. This apple-shaped body is a problem, right? If you've got this abdominal big gut, then you're much more likely to develop metabolic syndrome. If you've got more of this pear-shaped body, and this is mostly women, a little bit less likely, but still not great. You're still pushing the envelope for getting problems related to insulin resistance and insulin metabolism. So what do we know here? Again, the research focus here is on tendons and not ligaments, regrettably. But we do know that if you give mice an allergen, going back to some of our allergy talks and gluten and all that other stuff, that they show more signs of tendinopathy. Again, that's a mouse study and not a human study. And that we know that normal tendon healing is adversely impacted by low-level inflammation. Again, not much on ligaments. So listen, we know it's not a great thing to have chronic low-level inflammation. We know that the number one cause of chronic low-level inflammation is decreased activity and developing metabolic syndrome. And then we've got things like elevated MMP9. And this is basically just an inflammatory marker that it's a test you can get at Quest, so that's good. It shows elevated chronic inflammation. This is what's called a matrix metalloproteinase, basically a pro-inflammatory marker, and it regulates pathological remodeling that involves inflammation. And there's lots of things that link this to metabolic syndrome, and something as simple as taking fish oil omega-3s can possibly help this, at least in the lab. So the bottom line is we've always recommended to our patients to take things like a high-quality fish oil, curcumin turmeric, glucosamine chondroitin. What's different about these than the more esoteric supplements that are recommended is that these have randomized controlled trials showing they work to do this in humans. Hence, this is where I'm going to put my money if I had to make a bet on all this. I'm going to put less money on the more esoteric supplements. And then finally, clean up your diet. Listen, if you've got 30 pounds to lose prior to your PICL procedure, you should really focus on doing that. I think something could be very helpful. If you know you've got metabolic syndrome, then getting rid of that and getting your blood sugar under control, even if you can't exercise by controlling your diet, is a good way to do this and a good way to prepare. So conclusions based on this literature review. Again, I apologize for taking so much time here, but this is a deep and wide topic. So at this time, there's no scientific way to connect these functional med diagnoses to ligament damage. I'm going to continue to monitor this literature because this stuff changes all the time. And right now, we still focus on the two most common causes of CCI in order to make a CCI diagnosis. You've got to have some trauma or another congenital issue like HEDS that would be connected with CCI. And then just common sense advice, as I've been talking about: clean up your diet, lose weight, improve your sleep, take anti-inflammatory supplements that have randomized controlled trials that show that they tend to help people with chronic inflammation or things like arthritis. And listen, if you want to try some supplement medication or protocols or treatments for these functional medicine diseases, I don't really have a strong opinion one way or the other, just as long as that doesn't impact what it is we're trying to do with your PICL procedure. Just realize that for many of the newer supplements, I can't go on to PubMed or the U.S. National Library of Medicine and find out if they might have an impact on your stem cells like I can with some of the more established ones. The same thing for medications. Obviously, you got to review all of that with your doctor and us. So that's it. Let me stop the sharing. Again, I apologize for the length of that one. Hopefully we kept enough people on here to get some questions answered, either about this or really anything else. So let me go to questions now. Looks like we got lots of questions. Okay. Jimmy O'Neill, one symptom of my PTSD is shaking. Standard drugs have not been able to address it, so I'm looking to psilocybin. We talked about negatives of marijuana. If one goes the PICL route, I'm curious if any issues with psilocybin. Listen, there's a big national push right now to make mushrooms legal. I see both sides of that argument. On the one side, I'm pretty pro-drug legalization. I was pro-marijuana legalization. The problem becomes we don't know a lot about psilocybin, just like we didn't really know a lot about marijuana when it was approved here. We were the first state, I think, in the union to have recreational marijuana. So I've probably had this experience longer than most people in other states. And as doctors, we were kind of blindsided, for example, by the fact that patients on marijuana require dramatically increased anesthesia requirements, and that the risk of anesthesia increased due to marijuana. What psilocybin does or mushrooms do to any of that, I don't think anyone has any idea yet, because that research hasn't been done. They haven't been legalized enough for us to know. So that's my biggest concern there, is just the unknowns. Brian, is TNCC a reliable proxy for MSC count? If a patient has a low MSC count, not TNCC, do you ever see significant increases in future BMAs? How many BMAs can you have in a lifetime? Let's kind of break that down. So is TNCC a reliable proxy? It is a reliable proxy when you look at a population. So that means that if I look at 100 patients with a higher TNCC, they're going to do better than 100 patients with a lower TNCC, at least based on the research we've published. Now, the problem is that on a case-by-case basis, in any individual patient, there can be a disconnect. So you can have someone with a low TNCC who's younger and has a lot more stem cells per unit volume, or at least stem cells that will grow quicker in culture. That's probably a better way to put it. Not really more cells, but their cells will be more active. As far as whether or not one BMA affects another, we've done that research. Pretty sure it's been submitted, so it may come out here pretty soon in the peer-reviewed published literature. But the answer is we don't see a significant impact in anyone other than postmenopausal women. In postmenopausal women, you got to leave a much longer distance between those bone marrow aspirations, or we've got to do it a different way in that woman. So what I mean by that is, let's say we've got a 60-year-old woman, we go ahead, we do a bone marrow aspiration, and 4 months later we want to do a second one. Our research would suggest that you can do a second one. You just have to do it using a different technique, going after a different pool, because there will be dilution in that 60-year-old woman. Not a 60-year-old man, not a 40-year-old woman, not a 40-year-old man. So that's what we see. Manuela, is SSRI medication allowed together with PICL treatment? In general, we don't see problems there. But again, I can't say that we have as much information about all this as we would want, meaning what we'd really want is patients with SSRIs or not, and placebos, and then do these procedures and see who does what. But we're not at that point at any time soon, or anytime soon will we be there. Justin, this is awesome. You're the leading expert in Gen Med talking about Lyme and its connection to healing, connective tissue. That's how I ended up here. Some big injuries and then PRP that didn't help as much as I'd hope, instabilities and degradation of ligaments. To then, after lots of struggle, finding out I have Lyme and co-infections, treating those now, remain hopeful to heal and return to regenerative medicine. Sure. Rachel, Dr. Centeno, I have a CCI diagnosis. It's been stable since I had my first PSDL last October. I've been doing some PT recently, which has been enough to change my AO vector. I'm symptomatically about the same, but I do feel a little stronger. However, 2 days ago, I started a very scary new symptom when swallowing. There's a bit of gurgling, and it's not going all the way down, particularly in a low velocity situation like swallowing saliva. as opposed to food or water. Yeah, Rachel, so let's see, you had a PICL last October, so I'm assuming that's October of 2021. Just realize that what we saw, and I think I've talked about it here a few times, is during COVID, we kind of had a natural experiment, right? We had patients, some of whom were coming in regularly, COVID be damned, and others who put 6 months, 9 months, 18 months, longer periods of time between their procedures. About half of those patients maintained gains. About half of those patients went backwards. I think the half that went backwards probably had more ongoing wear and tear. So their normal repair couldn't keep up with it. So they're the kind of patients that needed ongoing treatment that was closely spaced. So let's say every 4 months or 6 months rather than every 12 months. So you could be in that category of a patient that needs more ongoing treatment in order to get to the other side, and that those treatments are spaced closer together. As far as swallowing goes, that can be due to just pressure on the esophagus and swallowing mechanisms. For instance, I've seen a lot of patients with just standard old whiplash who develop swallowing problems because of injuries to the anterior and longitudinal ligaments. So what I would want to see is on your flexion extension radiography or on your DMX, is there instability in the anterior longitudinal ligament? Meaning, does one vertebra go backwards on the other with extension? And if that happens, then we might need to treat that anterior longitudinal ligament directly. Regenix, submitted advanced by Oleg. Dr. Centeno, in theory, could flat feet, collapsing arches be treated with injections? AFAIK, they are caused by bad connective tissues. So I don't know what AFAIK means. Maybe I'm too much of a boomer. So listen, Oleg, as far as flat feet is concerned, I think ongoing continued collapse, in my experience, can be treated. What I don't know is that, for instance, if we gave you arch supports and then aggressively treated those, we could get those arches to maintain themselves and go back to normal or something close to normal. So that's still an open question. Kristen, great topic. I had MCAS triggered by Botox. If my MCAS doesn't get under control, it will continue damage. Well, remember, Kristen, we don't know that MCAS is related to ligament damage. I just went through that literature at this point. To the extent that it's causing chronic inflammation, that's probably not good, but we don't have any evidence that MCAS leads to ligament damage at this point. Fate Jun, I started getting my first in CCI, orthostatic headache and tachycardia, 2 months after COVID infection. In January, I totally recovered from it, though, and apart from 2 days of fever, I only had a cough for a few weeks. I know a few people who linked their CCI 2 months after their COVID infection. Maybe a group of predisposed individuals because years of bad posture, inflammation, or virus triggers it. Yeah, Fechin, I don't know that anyone knows the answer to this. My sense is that we probably will at some point. There's so much money going into COVID research and long COVID right now that perhaps someone will do a much better study on this. But right now, we just don't know. And the problem is that a certain percentage of people are going to have these problems based on injuries that were a long time ago. They get to that age and or postural scenario that breaks the camel's back. And does COVID play a role in that? We just don't know yet. Submitted advanced by Harry Winston. Can CCI cause systemic inflammation or issues like MCAS? It's a good question, Harry, and that's a question I think that I'd love to see answered by somebody. I may do it at one point in my career going forward. I don't know. I can certainly tell you that I think, and again, this is in the what do we think level, not the what do we know level. I think there's a relationship based on what I see clinically between things like spinal stenosis and inflammation, and or things like nerve root impingement and inflammation. So, for instance, we'll see lots of patients with an irritated nerve root in their neck that develop tennis elbow. And I think that what's happening there is you're getting dysfunction in the muscle, which is pulling on the attachment beating up the tendon leading to tennis elbow. So is it inflammation? Well, the inflammation is probably being caused by the muscle dysfunction. Now, I wouldn't be surprised if we found out that chronic nerve irritation may cause more neural inflammation, which then leads to systemic inflammation. So listen, we may find these things out. We don't know them right now. I'd love to see those questions answered. Stacy, let's talk about knees for a second. I had 3 PRP, leukocyte rich, and 1 bone marrow injection. Probably not leukocyte poor if it was bone marrow. All bone marrow injections by definition would be leukocyte rich. And my kneecaps are still crunchy and my right kneecap is so painful. Should I have arthroscopy to shave the cartilage and more injections of some type? Yeah, arthroscopy to shave the cartilage, it would be called a debridement. We've known since now a long time. I'm going to say the Baylor study on that was done in 2005. So we know since 2005 that shaving your cartilage is no better than a placebo faked surgery. So if we take 100 people and we shave their cartilage, called a debridement procedure, in 50, and in 50 we do a fake procedure, meaning we put them into the OR. We make a big deal of it. It looks like we're doing a procedure. We open some arthroscopy portals. We close them. We don't do anything. That there's no difference between those two groups. So I would not get a surgery that we know that doesn't work, which is shaving cartilage. As to whether or not more sophisticated treatment might help your problem, I'd have to take a look at your individual case, see exactly what they did, how concentrated the PRP was, how concentrated the bone marrow was, where they injected it, etc. Deanna, patients with osteophytes, where do you need to inject above the atlas for PICL? Do these patients have successful outcomes injecting only one side? Well, it wouldn't be one side. I think what you're talking about is an osteophyte extending below the atlas. And so in a percentage of those patients, it's all, we may or may not be able to get in below, but usually we can. So about 2/3 of the time, then we can get in below. It has to do with the width of the bone spur and where the bone spur is blocking the entrance underneath the atlas. If for some reason it is blocking in, let's say, 1 out of 3 patients, then we can usually get done what we need to from above the atlas where there's no bone spur. So hopefully that makes sense. Pia, thank you for this. I think inflammatory process is a big one in CCI. Mold for sure trigger here. 30-year-old or 30-year older than my son, and we have completely parallel issues. POTS, MCAS, CCI. I was completely healthy at 37 until the mold hit. Maybe looking research on Grisel syndrome, non-traumatic AAI associated with inflammatory conditions in the head and neck. Yeah, so Grisel syndrome is a thing that happens in kids where there's a subluxation that they're generally born with, and that leads to spasmodic torticollis usually. So different topic altogether. But again, as I said, Peter, right now we don't have research connecting mold to CCI. It's not even in the early stage, meaning the early stage would be, let's say we have some animals, we expose them to mold. We then see ligament damage in those animals. We don't have that research at that very basic science level. What I see out there online in making, like I said, a connection between mold and ligament damage is a bunch of stuff that looks very scientific if you don't know science and you don't read science all day, but once you actually look at the references and try to dig into it, it's not real scientific, meaning that I think A is connected to B, and B is connected to C, and C is connected to D, and D is connected to F, and F is connected to ligaments. But there's about 5 or 6 assumptions between those two things. So, you know, maybe one day there's a connection that's established, but we don't have the research supporting it right now. Fatcha, the only thing noticeably in my MRI is reduced cervical lordosis. Yeah, you know, the best thing there would be to have one of our doctors look at that MRI, because what the radiologist is reading out and what's actually there are sometimes two different things. Ben, in a video, Ron Hansen described that the side of the C1C2 facet capsule could be likely a culprit of C1C2 overhang. That is unlikely. Overhang is only caused by the alar ligaments. Thoughts? Yeah, I mean, based on the research we have, that study has been done. That study was done, I believe, by Dvorak, and they cut various things looking for atlantoaxial instability. The facet capsules certainly play some role in C1C2 instability, but realize that C1C2 is an incredibly mobile joint. So those facet capsules are going to be quite different than facet capsules lower down, meaning they're going to be bigger and looser to allow that motion, meaning you've got 50% of your rotation that's happening at C1C2. And because you've got 50% of your rotation there, those facet capsules are extremely loose. So they didn't, by cutting those capsules in the Dvorak study, they didn't add a ton of instability. So I doubt that's an accurate assessment based on what we know in the research. Now, as far as getting into the side, that's also extremely risky at C1C2 because that's where the vertebral artery runs there. So if we wanted to try to get into the outside capsule at C1C2, we'd be risking doing a vertebral artery injection. So is it possible to do? It's possible to do. It's just much higher risk than even the PICL procedure. And you'd need something like digital subtraction angiography to make sure you're not in the vertebral artery. Because if you inject, let's say, bone marrow concentrated in the vertebral artery, that's a bad day for everyone, meaning, you could cause a posterior circulation stroke and or kill the patient. So a little bit more complex than that. Fatchen, for patients with instability caused by infection, but made much worse by chiropractic neck manipulation and massage, would you recommend diagnostic treatment in your clinic? Yeah, Fatchen, I think we'd have to do a telemedicine to answer that question. So you'd have to get on a telemedicine. We need to look at your information, whether or not you have craniocervical instability based on our definition, number one. Number two is, I think, as I've just reviewed, we don't have information showing that CCI is related to infection at this juncture. So we're going to cross that one off the list for now, since we don't know that happens. And then we need to look at where you're unstable, why, et cetera, to talk about what links to what as far as treatment is concerned. Brett, watching this live in your clinic an hour from PS over to Dr. Pitts. Oh, sure, Brett. That's pretty funny. Yeah, good luck with Dr. Pitts and the PICL. Wish you the best with that. Kristen, if you have muscle atrophy from a heart collar or something else caused by that, damage ligaments and damaged facets because loss of muscle creates instability. Yeah, Kristen, certainly if you have atrophy in those upper neck muscles and they're not doing their job to stabilize, you're going to get more wear and tear on the facet joints and on other structures. So I think that's what you're saying here. Fatchen, you've been posting your questions, so I've been going through those. Let's see. Diana, do you know which type of medical insurance that Canadian international patients have purchased when traveling for no medical procedure? That's a really good question. I don't, but I'm sure in the PICL Facebook group run by Dan Semrad that there's probably patients on there that have encountered that. And they can probably tell you which insurance companies are a thumbs up, which ones are a thumbs down, which are expensive, et cetera. So better question for the PICL Facebook group. Deanna, when does atlas subluxation become dangerous? If it does, would AO be able to see risky situations on X-ray? I don't consider AO risky really in any CCI instability situation since it's so gentle. So I think that's what you're asking. Ben, in the video Ron Hansen described, I think I got that one already. Oh, as far as I know, thanks, Janelle. I am too much of a boomer for that one. I do get things like LOL, GTG, because I do that with my kids, but I haven't had my kids use that one. So thank you for the education to my boomer mind. Manuela, Injured 1 year, did first PICL in April. I've gained stability, feel more alive, and we'll do second PICL in October. Great, Manuel. I'm glad that we could help. Kristen, thanks, Dr. Centeno, for working on my inflammation, trying to figure out how to get it down. Sure. Diana, for PICL, after we pay the deposit, is the rest of payment due via credit card on the day of procedure? That's a good question, Diana. Over my head, meaning I don't deal with all of that. That's going to be a good question for Carla, who can answer that one. Let me know if you don't have Carla's email. I'll put it down below. Manuela, injured 1 year ago. I think I got all that. Pain is still at C1, no other symptoms besides pain. So Manuela, what we may need to do, and we've done this in some patients. So some patients, many patients will have their pain go down as they get more stable. But we may need to do some diagnostic blocks to find the source of the pain, and we have to do that in some patients. So just keep that in the back of your head. A diagnostic block means that we've injected numbing medicine, numbed out that spot, and then try to see if that pain goes away. Janelle, I know the more unstable my CCI and AAI became, the more reactions I had, re MCAS after my stem cell SCP procedure. MCAS lessened greatly. I did have one episode of severe heightened reaction in the months post-regenerative procedure, but regulated. Yeah, so Janelle, it's interesting. Certainly interesting to hear that. I have heard other patients say that, so that's encouraging. I'd like to, like I said, we need more research on all of this stuff. So it would be great if we could see more mast cell research on as it relates to instability, but right now there's just not much. Kristen, if CCI causes systemic inflammation, MCAS, how do you recommend patients treat in order for not to affect ligament healing? I don't think we know that CCI causes systemic inflammation or MCAS. I think one of the factors in CCI is we see a dramatic decrease in activity, which we know leads to metabolic syndrome, which we know increases inflammation. So whether or not there's a direct relationship between the CCI or an indirect relationship of marked decreased activity causing systemic inflammation, that we don't know. But what you can do is you can work on everything else, right? You can, I'm just going to make up an example. Let's say you walk in, we've got some guy who is going to get a PICL procedure. He's got 4 months to prepare. He's 40 pounds overweight. Why not lose the 40 pounds, which is going to dramatically improve your systemic inflammation? Let's say he eats too many hamburgers. Why not get rid of the hamburgers and eat clean, which we know can help reduce that inflammation? Why not up all the anti-inflammatory supplements during that time? All of those things are things we can control. So my sense is work on the things we can control that are easy to do, rather than the things that we just don't understand yet, i.e. whether or not CCI is causing inflammation all by itself. Diana, I had my first bout of vertigo last week. Can vertigo be caused by a subluxed axis compressing vertebral artery? No, the more common cause would be, and this is in the book that I wrote, is bad proprioceptive or position sense information coming from the upper neck, and that leading to dizziness, imbalance, etc. And then Janelle, sure, Janelle, thank you. Okay, guys, well, I do have a hard stop today at 2 p.m. my time, so I just have a few more minutes here. I'll answer any last minute question. But what we talked about today is what research do we have that connects all of these functional medicine diagnoses to CCI. And I wish we had more research, but we don't have a lot of research. And I would be a little careful of what I call stuff that sounds very scientific, but isn't. So that would be, like I said, A goes to B, and B goes to C, and C goes to D, and D goes to ligaments. That's all interesting stuff that would take a decade of scientific experiments to prove. So we need to be careful of that kind of stuff. Ben, is it worth to pursue posterior PRP injections between PICLs? No, I don't think that's a good idea. The few patients we've had that tried that, a lot of them have crashed and burned, so I wouldn't do that. Just a thought, if you have an idea for a lab who could offer hydroxyproline tests worldwide, I think all CCI patients could have this measured if high. Yeah, P, I don't think we know any of this. I'm sorry. It all sounds very scientific, but I don't think any of what you wrote is grounded in any known science at this point. Can chiropractic manipulation trigger CCI by themselves? We have seen that happen on rare occasion, that overly aggressive long lever chiropractic manipulations seem to have caused CCI in a susceptible patient. So I think it's possible. Diana, is there any benefit to trying PRP first? Wondering if I should dive into PICL, but I'm nervous. Yeah, Diana, we always give patients that option to try a posterior PRP procedure if they're at all concerned that PICL may be too aggressive for them. So that's really up to the patient. We'll let you know what we think the odds are of each helping, and then obviously you have to make that final decision. Okay, guys, so I'm up against my hard stop. I hope this was informative today. Again, oh God, this was a hard one. Probably took me 5, 6, 7, maybe 8 hours in total to research. I'm going to put this stuff on my blog tomorrow, so it's going to be in writing with all the scientific references there. So feel free to go to the Regenix.com blog. So you go to Regenix.com, 2 X's, and then go to the blog, and all of this stuff will be there written out. And I think I've got about 6 hours into this right now. By the time tomorrow gets around, I'll probably have another 4 just to make sure that I get all the T's crossed and the I's dotted. So thanks so much for visiting with me today. I will be doing this on Monday. I won't be doing it on next Friday. So I will see you on Monday, and have a wonderful weekend.